Now, all this revolves around our mantra, which is putting patients first. The first year that I was CEO, my first speech I gave to the organization, I handed out 40,000 buttons that said patients first. Because I realized that the only reason we had a job, the only reason we had a hospital, a clinic, or got paid was because of what we did for patients. And from that, we realized that there are three things that we needed to do. We needed to create access, we needed to provide quality, and we needed to have it affordable. And let me tell you some of the steps we've taken in each one of those directions. In terms of access, we have partnered with CVS. We have 11 facilities around the Cleveland area and are looking to develop more. We have partnered up with a new facility called HealthSpot. HealthSpot provided these, which are essentially overgrown photo booths. They have in them a screen where you can see your healthcare provider and they can see you. There is opportunities to take blood pressure, look in eyes, ears, nose, throat, listen to the heart, and you can imagine the opportunities that this provides. We've just placed one, for example, on one of college campuses. And we can think that you can expand the reach of primary care enormously in this way. The second opportunity that we've done is we've begun to look at mid-level providers. Reference was made earlier about coming back from corpsmen, coming back from Vietnam. That's essentially what our experience with this was. We've obviously grown our core mid-level providers enormously over time. They staff these HealthSpot facilities, and they help in the operating room. Cardiac surgery has 80 mid-level providers working for 12 cardiac surgeons. Our ED visits continue to expand. We're seeing some 44,000 a month, but at the same time, we've changed our method of how we see them to split level split flow. And now the average wait is 11 minutes from door to doctor across all of our emergency departments. A number of years ago, we had an interesting case, and you always learn most from a case. The patient called up and said he'd like to see a urologist, and he was given an appointment in 2 weeks. Turns out that that patient was an acute urinary retention. What we realized from this is you can't tell when someone calls up for an appointment whether they need to be seen or not, and you have to ask them. So we ask everybody, do you need to be seen or would you like to be seen today? So we then set up a system of same-day appointments. We'll see about 1.2 million same-day appointments this year, and 98% of the people who asked us to have a same-day appointment actually get one. We also have begun to engage people in their charts. 1.8 million people now have access to their electronic medical record. We started 8 years ago opening the medical record in all of our facilities to patients, and now we've done it electronically. Everybody who comes to the Cleveland Clinic is given access capabilities to their chart, and we have now almost complete information from their chart available to them online. We've also gone mobile so that you can get the results of your tests and make appointments, et cetera, on your handheld device. As far as quality is concerned, we're delighted that U.S. News and World Report ranks us right up there with your best here in Boston. For 20 years now, we've been #1 in heart and a number of other specialties. And we're delighted with that, but we don't really think that that's a measurement of quality. So starting 10 years ago, we asked each one of our institutes to do an outcomes book. And we now send out, and the reason we did this was twofold. First of all, we thought it's important for us to look at the data on our individual outcomes on a regular basis, and we learned that in cardiac surgery. And in fact, every time we looked at our outcomes, we found that there was problems in some location, and we work on it, and they get better, and as results, continuously improved. We're a big believer in data. But in cardiac surgery, it was really pretty easy. The outcomes was sort of binary. You either walked out or you got carried out. It's not so easy in dermatology, rheumatology, or diabetes. So we asked each one of the institutes to develop their set of metrics. We now, in these outcomes books, report 1,300 outcomes across, and each one of the institutes has one of these. It's available online or in paperback form. We benchmark ourselves as far as quality is concerned. The University Hospital Consortium of Quality Rankings, when we first looked at it in 2010, I was not pleased where we were. We're 80th out of about 110. We've moved progressively up, and in 2013, we're 14th in that quality ranking. We also look at patient satisfaction indicators, and better known as complications across all of our hospitals and all of our locations, and we cut those in half over time and continue to work on driving those down. Readmissions continue to be a problem for us, and as they have been stubborn across the entire country. But we're very transparent about how we report this, both publicly and to our individual physicians. Thromboembolic events similarly have been stubborn, but are improving slightly over time. Hospital-acquired infections have come down enormously. Again, being transparent about each one of these complications. Caregiver engagement of all of our caregivers, and by the way, we refer to everybody who works for the Cleveland Clinic, regardless whether they drive a bus or work in a loading station or a neurosurgeon, as a caregiver. It's part of our team approach, and we think that any one of those is vital to making the patient's care and experience as good as it can be. So we continue to measure the caregiver engagement and with Press Ganey, and we're in the 87th percentile. Our patient satisfaction was terrible in 2008 and embarrassing. Hospitals more than 1,000 beds, of which there's 1,700 or 17 in the country. We were dead last, and we've gone from last to first over this period of time. As the caregiver engagement has gone up, and as our patient satisfaction has gone up, we've seen complaints come rapidly down. Our major complaint right now is physician communication. And so we have now addressed this by taking all of our physicians offline for a full day in communication course, and they're beginning to show improvement. Affordability is probably the third of the important things that we needed to approach, and we've looked at everything across our hospital's system. Our energy usage index has come down substantially by doing everything from changing light bulbs to encouraging people to turn the lights off at night. We have put stops in our order set to eliminate a redundant lab tests, and have eliminated some 18,000 redundant lab tests as a result of that. Let's see here. We've gone heavily towards shared medical appointments. Interestingly, this has been a great patient satisfier, as well as in improving the efficiency of physicians. Patients like it because they see people with similar problems and realize that there are opportunities to share their experience with other people. We've looked at individual procedures and asked the groups to begin to look at everything from the sutures that they use in the operating rooms to the time, to the medications, time and recovery, et cetera. This is just an example of partial nephrectomy with a 20% reduction in cost. The interesting aspect is that very few physicians know how much anything in the hospital costs. So we have posted in operating rooms and cath labs, et cetera, by cost, how much things cost. It's been a big eye-opener for a lot of physicians. We have, interestingly, put on the patient's ordering orders for the physicians about blood transfusions. It costs essentially $500 per blood transfusion. But people recognizing that, we've begun to see a decrease in blood utilization, which is both clinically good and financially good. Behavioral health, for example, has changed how they begin to see people. They're seen increasingly by psychologists as opposed to psychiatrists, and reducing the cost per case. We've gone to care paths. We have almost 100 care paths that are either in use now or beginning to be used. This is just an example of low back pain, and we have reduced the cost per case of low back pain, cut it in half, and the potential is, should everybody follow the care paths, it would probably cut it even further. We've included everybody in the hospital system about how we could reduce cost. This is an interesting example. These two people recognized that only half of the irrigation solutions were being used and half of the prep solutions were being used, and the rest of it being discarded. So we reduced the size of the bottles, saving $300,000 across our organization. And we have a program called My 2 Cents where everybody can put in their suggestions. We've had amazing suggestions from the rank and file of the organization. So if you look at these three things together, we think that this is what's going to actually provide value for our patients and for the healthcare delivery system. And we continue to work on all of these. Now, I think all of us have to remember that there's only one reason that we're in healthcare, and that's the patient. And Theodore Roosevelt said that no one cares how much you know until they know how much you care. We put together a video for our organization. It was done in-house, and I'd like to share that with you if I could. I think that while we talk about the importance of driving the value of both quality and cost, we cannot lose sight of the fact that we're dealing with human beings, and empathy is an important aspect of what we do. We, in fact, have a privilege, and we cannot lose sight of that privilege of taking care of people in their most vulnerable times. Thank you for the privilege of coming back to Boston.